because I was not able to really understand how it works. I think ortho, like we have lots of orthos here. So ortho is the best specialty who understands bone. No one else. Like, okay, I'll give you my introduction. My name is Dr. Salman. I'm married to a prosthodontist. And when I started practicing implants, we used to have fights daily. Each fight lasted at least 3 days. And not talking to each other was even worse because we have to talk to each other because we have to restore the patients. So tell me exactly, when Dhruv was talking about occlusion, what is exactly was the base? Or what are the things which are involved in implants? See, if you don't answer me the questions, I will be here for the whole day. I'll miss my flight to Kochi. I need answers. I need you guys to think from a different perspective. I can be here, I can be a very good nighted, suited speaker, and I can show you my cases, all of them perfect, very good soft tissue profiles, long-term success, 10 years cases, 20 years cases. But how will you achieve it? You're not here to see whatever I'm going to show you, my success stories. I want you to think. I want you to think exactly like I was thinking when I was in your position. I wanted to know, how does the bone work? How does the tissue work? What is occlusion? Tell me, what is occlusion?
Contacting up to occluding surface.
It's just the forces. That's it. Nothing else. Occlusion is like two hard structures colliding, and that's how you break things, you chew things, and then you just solve it. So everything in implant dentistry, it's actually based on occlusion, yes? And there is behaviors. Behavior of bone, even in bone, like I'll go to the very cellular level of it. You might be thinking it is boring, but I really need you to understand what I'm trying to say. So when you think about bone, let's go from the outer zoom lens to the inner zoom lens, okay? When you talk about the bone, what are the two types of bone you have? Cancellous and cortical. What are the cells you have inside the bone? Only 3. Osteoblast, osteocytes, and osteoclasts. Each have a dedicated function. The way we look at bone when we plan the cases, as if it's dead. But no, it's a very, very good dynamic living structure. And all these cells are actually dancing. According to the latest research papers, there is a new concept. I think if you already heard about this, it's called as osteoimmunology. Like you can Google it and you can find really recent papers on osteoimmunology. So what is osteoimmunology? Any idea? It is actually a dance between these cells. So all the cells inside the bone, they actually do a very nice dance. And as you age, this dancing is slowed down. So whenever you're doing a case in a very young person, and whenever you're doing a case in an old individual, everything changes. Load also changes, the behavior also changes. And this is the line that you need to think on that will help you achieve long-term success. Osseointegration can be achieved by any company, any system in the world. Titanium, you put it inside the bone, it will integrate. There is no other way for this. If it's a sterile environment, and if it's a titanium, you put it inside the bone, it will integrate. But what happens next is the story. What happens next is the load is coming on top. You have to dissipate the load. The second thing is the tissue behavior around it. So the whole of implantology is only 5 cells. Only 5 cells. So you have osteoblast, you have osteocytes, you have osteoclast, you have epithelium, and you have connective tissue. Tell me if I'm missing something else. Is there any other cell I'm missing? Is there any other cell? Ortho. Residence. I think you guys are new, still reading. Is there any other cell I'm missing? Apart from this. So we have the biology and we have the mechanics. So implant is the mechanics, and biology, it's nothing changes. It's the same for each and every human being. It can be faster, it can be slower, depending on the physiology of the patients. This is exactly what I'm talking about. So these are some of the books which are dedicated to implants. There are more. If you want to read, you can contact me. I can send you a lot of books. I have read all of them. I wasted plenty of time reading them. Same topic from each book, and then I'll give you what I learned from them. But still, there is much more to learn. You won't believe there is a book on each topic on implants. Each topic. If you pick the topic of immediate loading, there are more than 5-6 books only on immediate loading. If you want to talk about implant mechanics, there's like thousands of books in total that you can choose and you can select and you can read. But I'm bounded with time. I only have 60 minutes, so I'll try to rush it as soon as possible. So everyone knows this picture, right? Brenmark with his first patient, cleft lip, cleft palate. The story behind this picture is, I love to have my relationship with my patients like this. Sitting on a bench on the garden discussing about how did the treatment went. It's impossible to achieve actually. This is the second patient. And this is the 7th patient. The longest living implant patient in the world. He died at 117 years of age. With implants still functioning. So if anyone comes and tells you that implant doesn't work, it's not like that. There are too many parameters around it, and everything can be calculated. I'm actually speaking about this calculation because I'm working also with the R&D team of root implants. So I'm developing a lot of things, and believe me, everything is calculated. Even bone remodeling can be calculated. So just let the AI step in and you can just type in something and it will give you the prognosis of the patient that it will last for this amount of days with this amount of plaque. So 95% success rate after 55 years. It's quite longer than bridges. Bridges usually fail 15 years. Sir will know this very well that any bridge cannot last more than 12 to 15 years. Either it will be secondary caries or there will be gaps, there will be marginal leakage and blah blah blah. So this is the workflow for implants. So we start from bottom to up. So we have the first and the foremost is the treatment plan. What to do when? If you do the treatment planning correctly, you will already know the mistakes or the complications which are about to happen. If you don't do the treatment planning, if you just see the bone, select the implant, place it, you will always have a problem. Second thing is, you always use reliable products. Don't use companies that are just entering the marketing and exiting just on the base of price. Third thing is, surgical skill is something that you can learn. No one is born with it, everyone learns it. So if you see a good oral surgeon who's performing very, very complicated procedures, it's not like he's blessed, he just learned it. And everything can be learned. I can learn. I can still learn if you want to teach me something, I can still learn. I even got to learn recently that there is a different way to give knots in different types of sutures. So I just got to know it really recently. So you can attend courses. What I would love you guys to really learn is suturing. If you can open the flap and if you can close the flap, it will heal. This is the must. You should learn it. Suturing is a skill that should be acquired by any surgeon. If you can open the flap optimally and if you can close the flap optimally, the healing is there, unless and until the patient is compromised by any health or any issues. Then patient compliance. Like most of the patients that I did in my life were not compliant. That's exactly what Dhruv also said, that the warranty or the validity of your implant is not void if you don't have a follow-up. So usually it's a 6 months follow-up post-implant placement. So the patient should come and show you each 6 months. If he's not doing it, if there is a damage, you cannot control it because it will already exceed by 6 months. So if there is a bone remodeling or a bone loss which has started already and the patient is coming after 1 year, maybe it's gone 2 millimeters and you don't even realize it. and there is no way you can get it back. So always play by the rules. There are rules that we need to consider. If they're like exactly we have rules for each and everything. For crown preparation we have rules. For ortho we have rules. For endo we have rules. Similarly, implants also have rules. If you don't obey the rules, okay, I'll give you a very easy example. If you over prepare the endo canal by 2 millimeters, what will happen? If you are beyond the apex, what will happen? Pain, problems, complications. Exactly these type of rules are existing in implants. You just need to stick by the rules. And the second thing is, you build what you don't have. So implant can only be worked with bone. If you don't have bone, you have to build it. If you don't have tissue, you have to do tissue building. So if you have these things, only then implantology is valid. If you don't have these things, implantology is invalid. No matter what treatment you do, you will always have complications. Either there will be bone complications, either there will be tissue complications. So just to avoid, I'll give you a step-by-step breakdown in this lecture, what you can do when, and when it's beyond your scope. So this is the oldest literature existing in the world. It was done by Dr. Benjamin Bell. It was written in 1796. So any surgery in the world, if you do it in this way, it will be a success. So first is sharp dissection, which is the most important thing. When you give an incision, you have to give a very, very sharp incision so that you reflect a full thickness flap. Second thing is gentle manipulation. If you actually play with your flaps, the patient will come up with complications and pain. Third thing is tension-free closure. This is where the suturing technique will come into play. And then avoidance of dead space. Dead space is actually a place where bacteria can enter and it will colonize and it will actually create long-term inflammation. So you are the architect of your own creation. You might have heard of this phrase every time, that implantology is reverse engineering, it is prosthetically based, surgically achieved. And it's true, because if you don't have a blueprint, you cannot replicate it. Imagine I'm constructing something in my house and I don't have a map for it, or I don't have a guideline. So I'll start constructing pillars and then I realize, okay, how will I make the roof? How will I make the room? So this is the most common problem also in implants. You see the bone, you place it, and now you figure out, you keep on figuring out, okay, what should I do now? Maybe I need an angled abutment, and it will just increase your cost. Nothing else. And there will be additional complications also. So if you have a blueprint, you can achieve it as it is. So it's always good to have a blueprint. Consider 4 things before you start implants. You need to know these 4 things. First, your patient. What is the attitude of the patient? Will he be compliant or not? Does he even understand the treatment what you are going to perform? Or he's just a random guy you are actually pushing him? In implants, the patient understanding is really important, because if the patient doesn't understand, he will be always coming and eating your head in the clinic. So, and there is always a chance that something might go wrong. So I have been dealing with one patient, even I placed it in India, the implant around 2012. And the patient is still bothering me abroad. And it is my mistake. Like Dhruv said, it is my mistake. It was actually an error in terms of planning. So it was an anterior case again. Usually anteriors will always haunt you for your life if you don't plan it correctly. So anterior case, and in this case it's not a failure. It's the problem, the tissue recedes every time. So whenever I'm in India, I'm traveling, I try to do some treatment to him for free. And that charge is almost like, if I calculate it, excluding my traveling cost, it has costed me around 1,20,000 rupees till now. From 2012 till now. So I performed almost lots of procedure. I'm sorry, I cannot show you. Like maybe in a complication lecture next time, we can show it. So we have 2 stages in implant placement. One is surgical, the other one is prosthetic. So First one is surgical biological, which is maintaining the blood supply around your implant system, or maintaining the blood supply of your tissues. One is the bone, and the second one is your soft tissue. And the second most important thing is the prosthetic phase, which is also the mechanical phase. It's stress modulation. It's to gauge how much stress is coming on top of your implant and how well it will be dissipated. So when we talk about the four things that I mentioned, you're knowing your patients, knowing the bone, knowing the tissue, and knowing what amount of stress that implants gonna take. If we don't have this, Dhruv gave an amazing lecture. It was really right on the point, and this is how you achieve it. Tell me the problem that you face with implants when you start. As soon as you start implant, the first problem that comes to your mind. The first problem, like I'm new to implantology, and the first complication I faced is this. Screw loosening. Okay, yes. Why?
Occlusion was not.
Exactly. Occlusion. Any other thing? Integration is not a problem. If you're using sterile environment, placing it according to the protocol that is narrated, it's not a problem. What is the other issues that you have? Prosthetic part. Exactly. We did a study on different random cases, and we just checked like what was the problem in those patients. 85% of the patients will only have prosthetic complications. Surgical complications are much later in the life, when the load is not exactly where it's supposed to be. So this is one of the articles by Dr. Dennis Turnow. He's one of the most renowned people in the face of implantology, and he had this principle. So he said that you should have this amount of space from the tooth to the implant, this amount of space from the inter-implant distance. And when he was lecturing, like it was a webinar, he was giving, and I asked this question: why this number? Why this number? Why it's not more than this? You guys are quite senior. You might have attended these lectures and you might have heard of these numbers maybe thousands of times. 1.5 millimeters from the adjacent teeth, 3 millimeters from the inter-implant, 2 millimeters from the buccal plate for higher aesthetics. So why this number? Why not less? No one thought about this. No one asked the question like why? Or just accepted it blindly, like okay, maybe there's a rule, we have to follow the rule. But why? Why this number? Why inter-implant distance is 3 millimeters? Why between tooth and implant is 1.5? No one bothered to ask this question. Think. Please.
Space for the plastic. You need the space for the plastic.
Yes, one part, but when you place it surgically, why this is the minimum criteria? Restoration is much later.
Ensure blood supply.
Exactly. It's actually the blood supply, because bone is a dynamic tissue. When you stress it, it will fracture. There will be microfractures. If it's not healed, these microfractures get converted into macrofractures. If it's not healed, it gets converted into epithelium or granulation tissue. So the case that Dhruv showed, what exactly happened in that case? Why do we have failures in implants, by the way? Why there is fibrous integration after some time? Why it's happening? It's because the stress cannot keep up with the bone, with the healing process. Somehow, like this, I'm giving you the rationale. Any implant failure, it will always come to this. It will not go to anything else, unless and until it's an infection. It's a problem with the sterilization. But imagine, the moment you chew, what happens? There is stress. Where does the stress goes? Inside the implant and the abutment connection. Where it's dissipated? At the crystal level. Or if it's a conical connection, it will dissipate it deep inside the implant. Each time the implant is stressed, there is elastic deformation which is happening around the area of the bone. So this peri-implant tissue or the crystal bone, so imagine my neck to be dissipation zone and my shoulders to be the bone. So as soon as my neck is stressed, it will transfer all the load to my neck, to my shoulders. These shoulders, how they behave, they create microfractures. So each time microfractures is created, I'm talking about the osteoimmunology. The bone cells are triggered. So the moment microfracture is created, osteoblasts are triggered. They will actually remove the dead bone, and at the same time there will be formation of the bone. And this process goes on every time the patients bite. What happens is, the complications, why it happens is, when the patient is not able to maintain the blood supply, which are the cases, smokers and diabetes. In higher age patients, osteoporotic females, it's already a faulted mechanism. The osteoclastic activity is higher than the osteoblastic activity. All the failures in the implants is around this zone. It will not go out of this. You can always track the failure in this way. It will always come with this. Microfractures, failing to heal, it will go into macrofractures. These macrofractures will not heal. They will be converted into epithelium or granulation tissue, and it will just keep on increasing. So, sorry, I think I need to. I'm sorry, I'm going to destroy your drawing. But this is you need to understand. If you understand this, you understand implantology. There's nothing else. Nothing else. All occlusion, all force, all stress, it's here. It's okay, I don't need. If everyone can see it here, right? It's a permanent one. So, this is the crest, this is your implant, okay, this will be the tissue. So every time when the bone is stressed, this area is having the stress, this is the elastic dissipation zone, and this area will create microfractures. In a good situation where there is a good blood supply, where there is a good peri-implant complex tissues, this, because of the blood supply and enhanced healing, this will heal. If not, it will create a bigger fracture even, which is a macrofracture. Again, this macrofracture will fail to heal. Because it's failing to heal, the body will try to block the inflammation. So the first cell that blocks the inflammation is the epithelium. You will always find epithelium in places in the mouth, wherever, like sinus tract. What is it? It's epithelial lining of the mouth. So this will gradually start to turn into granulation tissue. Now you lose almost 2 to 3 millimeters. The implant is 10 millimeters. This is the start of peri-implant practice. Still loading, still not healing. It will just progress, and the implant will die a slow, painful death. So immediate failure in implant will never happen. It will always be a slow, painful death. Will take around 1.5 to 2 years, because it is just the body is failing to respond optimally on a cellular level. So these are some words of wisdom. Tell me if I'm boring you, right? I get passionate and carried away sometimes with discussing all those things. So just tell me that, Salman, just move ahead. Don't go into too much details, okay? So these are some. So this like bone sets the tone. If you need to have a very good amount of bone. Second, the tissue is always an issue. So I'll give you just about how the tissue behaves. Then buccal plate, especially for anterior cases, is very important. If you don't have a buccal plate, you will always have complications. And implant position. Optimal implant positioning is something that you should always strive for, because bone itself is a tissue which is very good in taking axial load or compressive stresses only. Bone is very weak in taking shear and angular stresses. Shear is a twist. Okay, how many of you have twisted their ankle at least once in their life? If not, you guys are really blessed. Like at least once, everyone has twisted an ankle. But we walk every day. Why don't we twist the ankle? Like, why it's always a twist which pains? It's because bone is designed that way. The bone behaves that way. If I'm working like this, all the loads are compressive towards gravity. I don't feel anything the moment I work normally. But the moment there are angular forces on the bone always flips. It fractures or it breaks. So bone is like ortho again. Next time when you're doing rotational, just be careful. So these are the basic guidelines as we already discussed. So these guidelines are given for a reason because they need minimum amount of blood supply to heal. If you override this, you will always have complications like bone loss of tissue loss. Then this is a rule which is called as the Chris-Chan rule. This is the orthodontist who gave this rule. There's a very famous orthodontist from Hong Kong. His name is Chris-Chan, and he actually gave this rule for long-term success and maintenance of crestal bone. So he said you need at least 3 millimeters of bone from the corona-apical junction or from the free gingival margin. That is the biologic width of the implant. And for the long-term aesthetic success, you need at least 2 millimeters of buccal plate. Why? We will know. So what is the thin biotype? Aesthetic consideration, and there is thick biotype. Like there are two biotypes. Now I actually stopped talking about bone, I'm talking about tissue. So we finished everything what we have to discuss on the bone, we'll discuss about the tissues. When you have a thin biotype, the biologic width in tooth is how much? Young guys, what is the biologic width in tooth? Natural teeth. 1.8. How much is there in implants? 3.5 to 4. It varies. So if we don't have a good bone, there will always be a bone loss. It's because if you don't have the amount of thickness that you need, the blood supply will be hampered and it will either create resorption. Everyone has seen ortho cases where you are actually taking a Bimax proclination case intruded inside. What happens to the tissue? What happens to the tissue in such cases? When you're actually taking, like it's an, like say class 2 case and it is quite in front in proclination, and you slowly try to move the tooth behind, and what do you see in such patients? Yes, but what happens to the tissues?
Thin to thick bodies.
It gets thicker. Why it gets thicker? Why it gets thicker? If I'm your external, I'll fail you all. Because the bone is getting thicker. When you retrude, there will be tension and your plane will be formed, compression plane. The tension plane will have formation of bone. Because of this formation of bone, no one realized that this happens. Like I was like, okay, why this patient? Like that ortho is not my field at all. I just have a curious mind. That's it. So I was having a case. It was like for the crown lengthening, and I see huge, thick, beautiful tissue. After the ortho treatment, the patient came and they said, "Salman, you have to do CLP here." So I fixed the template, guided template. I do the CLP. I removed it. I reflected like I started trimming the bone, and there was good, beautiful thickness of buccal plate. So this is where exactly I know if you have good thickness of bone, the tissue will always behave in a certain way. So like usually the classification is like thick biotype, thin biotype, thick bone and thin bone. The worst is thin bone and thin plate, and it's like the other one is just compensation. So this is really, really important. Tissues only behave like the bone behaves. I give you a natural tooth example by orthodontic treatment. So when you retrude it, there will be bone formation, there will also be tissue formation. Also, when you talk about tissues, the tissues behave differently to different stresses. If you have thin biotype, and if you apply forces on thin biotype, it will recede. There will be recession. But when you have a really bulky biotype, thick biotype of tissue, and you try to have compression on it, it will start to grow. And this is exactly what was happening in that case. In the ortho case, tension was created, and the tissue was also getting thicker with each passing day. So this is what happens when you extract the tooth with a thin biotype and a thin plate. As soon as you extract it, and if you don't do socket grafting, it will start resolving. And it will create a very nice crater shaped defect in the patient, and it's very difficult to break up.